balancing the problems of the weather-related issues. And I guess it is appropriate to put smoking cessation first, which is what I'm going to address, since it's the proximal cause of about 90% of all what Frank is going to be talking about treating. So let's get right into it. Now, your handout has everything I'm going to say, but in addition, I've given you kind of a package of material that theoretically at least would allow you to go out and set up your own smoking cessation program. It has information relevant to state-of-the-art clinical practice guidelines, and as we'll see in a moment, I'll add some new information to this. But in addition, we have references to organizations that are just excellent in providing you as a clinician with practical information to use in your practices. One of the, we talked about clinical practice guidelines. This is sort of the book, if you will, 2008. And you can get one of these free by just sending your address in to the appropriate email on the back. And I would encourage those of you in practices, groups, etc., to have one of these around as an excellent resource document. In terms of reimbursement, if you do basically what is in here, you follow the guidelines, you can get reimbursed to the tune of about 85% of encounters with smokers if you kind of are set up to do that. But this is what is used by third-party payers to judge whether or not what you're doing is appropriate for reimbursement or not. So it's a good book to have. The other thing I would mention is the program at the University of California, Treatment for Change. Dr. Glanz's group out there is probably one of the best websites to go for more specific information about what you can set up in your practices to do just an absolutely first-rate job with smoking cessation, state-of-the-art. And you can go into this in great depth, or you can go to just that depth where we know you're getting the impact and effectiveness that we know is possible. But that resource is called Treatment for Change, and I have the website in your handout material, so I would refer you to that as well. So with that, let's fire away here. I'm going to talk just briefly about the toll of tobacco in general and in Indiana, and then focus most of the discussion on office-based tobacco use prevention and cessation. I'm going to talk about some special populations briefly, and some issues and some myths that are out there that we probably need to put to rest, and then try to answer any of your questions. First, the toll of tobacco use in Indiana. I'm sure most of you are familiar with these data, but about 20% of all deaths in the United States are still attributable to tobacco use, 90% of COPD, 30% of cancer deaths. That's a conservative figure. And 30% of cardiovascular deaths. We really are talking about the proximal cause for the lion's share of morbidity and mortality in the United States. The costs of this are staggering, as you might know. And interestingly, and a challenge for us is, over the years, this is a problem that's been concentrated in certain populations, the poor, the uneducated, and those with psych comorbidities. The other thing I wanted to point out is that most of us are smokers. We might say we're not smokers, but in fact, we know that we walk around a campus like this. I was just over in the library and chased a couple of students off the little porch there outside the library, smoking, God forbid, on this tobacco-free campus, right? And so secondhand smoke is a major issue. What Dr. Carmona said in 2006 was not new science at all. We've known this for a long, long time. But he said it from a public forum that there is no threshold effect for exposure to secondhand smoke. That is, there is no level below which it has not been shown in good science to have adverse effects on living things, including people. Secondhand smoke deaths a year, about 50,000 premature deaths. Most of those are cardiovascular. About 3,000 are lung cancer deaths, and so on and so on. The good news is, in part because of these kinds of statistics that we've been trying to communicate over the years, we finally, the planets aligned in some way, and President Obama signed the Family Prevention Tobacco Control Act in June of 2009. And this is the first time in American history that we have an agency of the federal government that now has the power to regulate tobacco, all phases of tobacco production, marketing, and sales, and so on. How this is going to turn out, nobody really knows, but already some good positive things have been done by the FDA in terms of taking the pleasant aromas out of cigarettes that are marketed and targeted at young people in the United States. Of course, you guys, good observers that you are, will know that unfortunately we have those aromas in little cigars that are now one of the more popular forms of smokes for young kids. What about Indiana? The toll of tobacco. High school students, fairly significant to some shocking figures, about 24% smoke regularly. Under 18 new daily smokers, about 10,000 a year. Kids exposed to secondhand smoke in the state of Indiana, we have one of the worst records in the country, about 420,000 cigarette packs bought by kids each year, about 20 million. And the adult per capita rates are now 21.2%. And that's actually good news from where we were, and I'll show you some statistics in a moment. We do have about 10,000 deaths each year in the state of Indiana attributable to tobacco use. Of kids under 18 living today, about 160,000 of kids living today under 18 will die from tobacco smoking. And the annual costs, a very conservative figure, about $4.7 billion in the state of Indiana, healthcare costs and the business costs associated with tobacco use. Of interest is how much the tobacco industry spends to market primarily to young people. It's about $300 million each year in the state of Indiana. The good news is the legislature in 2000 established ITPC, Indiana Tobacco Prevention and Cessation Agency, and it had a life of 10 years. And during that life, it was quite remarkable, and I'll show you some statistics. And these data are going to be, will appear in the CDC's Preventing Chronic Disease. If the editor is correct, she told me it would be about early January. So you might want to look for a paper that summarizes the Indiana story, if you will, in terms of ITPC, the statistics, and the reasons for its origin and the reasons for its demise in the legislature in Indiana this year. You can always tell when you're doing a good job in tobacco and smoking cessation is when you get put out of a job through a legislature. Just take a look at these data, though. You've got number of public school districts from 2001 to 2011. Here in 2001, the number of school districts with tobacco-free campus, and now today it's about 234. Universities, 1 at that time, 35 today. Hospitals, 0 campuses smoke-free, 133. Workplace, local smoke-free ordinances, restaurant ordinances, and so on, from 0 to 33. And much of this is due to a dedicated effort of the ITP staff, leadership, and their workers who helped administer coalitions all over the state of Indiana. So the money went from the tobacco industry, master tobacco settlement, to the communities in the state of Indiana to help these people organize state-of-the-art tobacco control at that level, support the clinicians, support the nurses, support the infrastructure and health. And it's been quite remarkable. Now, here are some data that tell the story. 2001, the youth tobacco rates about 31.6% and 17.5% today. This is just a remarkable reduction. In adults, 27.4 when we started out, and 21.2, the lowest per capita smoking rate in the history of the state of Indiana. So we're happy with that. Another figure that we're sort of proud of is the actual use of cigarettes. The number of packs, the number of cigarettes smoked per day has gone down, which is good news. However, I would point out in your patients, it's great for people to go from a pack a day to a half a pack a day. The problem is there is not a linear relationship between morbidity and mortality. That is, you still have very high morbidity and mortality even at a half a pack, at a quarter of a pack. That's why it makes sense for 50,000 people a year in the United States to die from secondhand smoke. Does that make sense? So it really is key to get people to cut back, but then quit altogether. So these are the sales in packs here, and then expenditures for the ITPC program shown here. We started out at the CDC threshold, which was 32 to 90 million a year. We got 32, which was terrific, and then very quickly the tobacco industry moved in full bore, and we have, by the way, a beautiful history of exactly how all this happens at that level. 312-page history of tobacco control in the state of Indiana from the late 1800s to 2010 by Dr. Glanz and his colleagues at the University of California, San Francisco. And we can show you where the lobby monies flow into the Indiana legislature in time for the various policies that are put on the table that would control tobacco use in some sort of way in the state. So there's a pretty good cause and effect there. The good news, however, is that even though the legislature abolished the board, the program itself is still in existence, and we're excited about that. It's called the Tobacco Prevention and Cessation Commission, and it's within the Indiana State Department of Health, Dr. Larkin et al. Now let's shift to addiction, which is what we're addressing here. The quintessential biobehavioral disorder, nicotine addiction, complex issue, a chronic brain disease, and a lot of exciting, great research has been brought to bear on this problem, showing at a cellular level what goes on about 10 seconds after you take a swig of tobacco smoke into your lungs. It moves across the alveolar capillary membrane and heads off to the brain. It takes about 10 seconds. And very quickly in animals and in people, you can begin to see upregulation of nicotinic receptors. And these are just some data that reveal that. So this is a disease which acutely and chronically and adversely affects the brain with addiction and the things that go along with nicotine, as well as the 4,000, 5,000, whatever chemicals in tobacco smoke. Alan Lesher, former head of the NIDA at NIH, came up with, I like short, concise sort of definitions, and here's one: compulsive drug use without medical purpose in the face of negative consequences. That can apply to all addictions. It certainly applies to tobacco use. Neil Benowitz in California has done great research through the years and has shown why it is that people come back for the next cigarette and why it's difficult for us to get them to quit. This is just a partial list of the chemicals that flow out from the nicotine, dopamine, norepinephrine, acetylcholine, vasopressin, serotonin, beta-endorphin. All of those things individually and together produce the effects on the brain that bring people back for another dose. And this shows you a typical day in the life of a smoker who comes back every so often for a hit of nicotine, up and down until night. One of the important findings based on a couple of decades of research into the brain effects of this disease is that treating chronic tobacco use, tobacco addiction, as a chronic illness is key, just as it is to treating drug addiction of any kind, diabetes, hypertension, asthma, what have you. And this just shows the percent of patients who relapse. So just as with a patient who has asthma or another disease, hypertension, we step back, try to understand why the relapse, and help the patient develop a plan to get it better next time. And we do the same thing for tobacco use. And this has now been shown in some good research to make sense. So treating drug addiction, tobacco addiction as a chronic illness is important. It's also important to recognize that it's not just the nicotine, but powerful socio-cultural factors and psychological dependence, the pairing of that hit in the brain with just about anything else you're doing at the time, it turns out begins to prepare a powerful bond that brings you back the next time with various cues in your environment. And some of the instruments that I've referred to in the treatment of change material that you can pull up on your website, they actually allow you, if you're so inclined, to quantify the magnitude in a given patient of these factors and these factors. And it's pretty neat stuff. The Fagerstrom test is, I think, probably one that you're familiar with, just what's the level of dependence to nicotine. Of that simple questionnaire, I just asked two questions. One, is the patient, how long after a patient wakes up before they take the first cigarette? And if it's within a few minutes, 5 or 10 minutes or so, that's 3 points out of 10. And if the patient smokes a pack and a half a day, that's another 3. So they are, by definition, a highly dependent smoker at that point, and treatment needs to follow that knowledge. Does that make sense? Okay, let's focus then on office-based smoking cessation. Why in the world in 2011 are we doing this? Why would we do it? We have good evidence that patients value preventive health services in general, specifically tobacco cessation. Good data that patients that come to us expect us to provide state-of-the-art services. Payers now increasingly value and pay for it, including federal as well as private insurers. Health reform and however this might roll out is going to certainly involve all of us as clinicians in doing a better job on the prevention side. Accrediting agencies require it. JCHO is going to update its regs here at the beginning of the year and add some things to it. So we're expected to do this in the hospital or in the office setting. Science strongly supports doing state-of-the-art smoking cessation. The economics is apparent, and there's a professional imperative, as I think we all know. The problem nationally is this: 45 million adults in 2010, about a fifth of the population smoking. The good news is many of them, about 69%, want to quit. About half have tried recently, but many of those people, about 68%, have tried cold turkey. Now, I always tell people, hey, if you think you can quit cold turkey, try it, quit. And if it works, it's 100% effective. If it doesn't, I'll be here and we can chat later. But don't discourage somebody from quitting on their own. And I think all of us have probably had the case. I had a 4-pack-a-day farmer who came in a number of years ago and told me that he really wasn't very interested in quitting. And I didn't make a big deal out of it. I just said, I think you really ought to start thinking about quitting. So about 3 or 4 months later, he came back to clinic, and I said, how you doing on the smoking thing? He says, well, I quit. And I said, dubiously, what do you mean you quit? He says, well, I just quit. You told me to quit. And how did you do it? Well, I just threw him away, Doc. It's a tough thing to do, but I got him out of the house, out of the tractors, et cetera, et cetera. And I'm sure all of you have had that story. So a little bit about cold turkey. It's not successful. Only about 5% of people who try to go cold turkey are going to quit with that. This is the guideline, the clinical practice guideline that I showed you, 2008. It's a compendium that's been updated since 1996, thousands of peer-review articles. The science is ranked, and so the recommendations have the level of science behind them. Is it an A or is it a B, and so on. These are the 10 findings from this effort, the clinical practice guideline. the bottom lines: treat tobacco use as a chronic disease, document tobacco use status, make sure that in your offices, the hospital, etc., you get this feedback, because if nothing else is done, just that feedback to clinicians demonstrates at 6 months to a year a significant increase in quit rates in people. Just the fact that you know that your patient smokes or not. So it's key. Encourage people to quit. Treatment works. Brief interventions are effective, but other interventions are also effective, and in terms of counseling, there is a dose-response relationship. For every minute that you add to the counseling intervention, you get increased quit rates. So the more you can do, the better, up to a certain point. And in the future, as we practice in groups together, our groups will need to have an organization set up to make sure that we get the best intervention for our patients to produce the best outcomes. The sixth thing is, the good news is we have 7 first-line medications. We also have combination drugs I'll mention. Encourage counseling plus medications. The 2 of those work the best. The great advance in the recent years is the quit line. It turns out that we're busy. We have a difficult time doing a lot of counseling in our offices, motivational counseling. The good news is we now have quit lines. A patient can call a quit line or be called by a quit line and receive all of this counseling. It's state-of-the-art, and it works. We have good prospective trials that show the effectiveness of this. Use motivation treatment for those unwilling to quit in certain populations. In pregnant women, for example, it's best to avoid medications unless it's absolutely indicated. And here, motivational interviewing is key. And by the way, the quit lines have pregnancy tracks. Those are available that you can access for pregnant women. And Indiana, we're trying to do more in terms of addressing the needs of pregnant women. And finally, treatment is effective and cost-effective. Insurance ought to cover it. This kind of gives you an idea of the outcomes. If you use state-of-the-art smoking cessation, you approximately double your quit rates. You don't go to 100%, you approximately double those quit rates. And if a person slips or relapses, you learn from it and you recycle and remotivate and help the patient learn how to do it better the next time. But studies from 18 meta-analyses, huge numbers of patients, show this in a monotonous way for the various drugs we use: gum, patch, nicotine lozenge, spray, the inhaler, bupropion, and varenicline. I would say right now that the best results, the science shows that the best results are with varenicline and with combination drugs. And those include the patch plus bupropion or the patch plus gum, etc. Those combination drugs, if you look at those trials, you get the best results. But I'll come back to the not so good news with varenicline in just a minute. Okay, just a note that with healthcare policies in the community, it's good for us as clinicians to support tobacco-free kinds of initiatives. We've got one on the table right now downtown, so if you know your policymaker, call them up and say, yes, we do need smoke-free Indy, and in fact, we need a smoke-free Indiana, right? But first, Indy, yeah.
You know that they just passed the Indianapolis one.
Yeah, oh yeah, I know.
Okay,
Right, yeah.
do you think that was wise? I mean, do you
It's,
think they're going to get what they really want?
it'll be on the table, and as long as the Super Bowl is still going to come to Indianapolis, it's going to happen. That's just my take. Does that make sense? Because we got hit as a city hard the last time what was that big group that came through? A few months ago, and we hit the national press because of complaints that Indianapolis was referring young people to the Slippery Noodle. I don't have anything against the Slippery Noodle. I've never been there before, but it's a tobacco zone, you know, and restaurants like that. And so there were lots of nasty letters. And so I think with the Super Bowl coming in, that may be a motivation to get the job done. Okay, it really does help if we have Insurers who cover the treatment, as you well know, physicians do a lot of pro bono work, but it's impossible to do state-of-the-art tobacco control unless there's reimbursement for services rendered. And so these are some of the things that studies show, everything else being equal, increase the quit rates in your community. So if you guys do state-of-the-art smoking cessation, and we do these things in the community, compared to communities that do the state-of-the-art smoking cessation, but don't have this stuff, we come out much better. So it's important for us to support. So given all this, where have we come? Tobacco rate today is in the 20% range. In the 1960s, it was more than double that. Most care organizations in the country now provide in some way or support tobacco control. JCHO requires it. We now have the federal insurance, Medicare, Medicaid, the VA, military offering treatment. And the good news is smoking quit advice has increased and doubled since the 1990s. So you are doing a good job and care workers are doing a much better job. We've got 7 approved drugs and quit lines in all states in the United States. As a resource, I just put a couple in front of you that I alluded to earlier. The American Academy of Family Practice, the Ask and Act program is excellent. And it embodies, and most of these programs use, the Ask, Advise, Assess, Assist, and Arrange, the 5 A's, and the 5 R's, the relevance, the risk, the rewards, the roadblocks, and repetition. And in your packet is a little pocket card, and you can just carry that around with you. And this 5 A's and 5 R's is based on wonderful studies done in the late 80s by the National Cancer Institute in clinicians' offices all over the United States. This is evidence-based. This stuff does work. Now, in your handout, if you go to the red packet, just pull it open right quick, and on the left side are 2 pages. Those are algorithms that are useful, particularly the one that is from the article in the New England Journal by Michael Fiore. It's a double panel one for patients willing to quit at an office visit and patients unwilling to quit as an office visit. This is a handy reference and kind of gives you a streamlined view. It looks complicated, but it's very straightforward in terms of how you triage the management of these patients. For a patient willing to quit now, you provide office support, positive, empathetic encouragement, brief counseling, and the nature of that counseling is available online in various places, but it's straightforward motivational counseling, a lot of support and encouragement. Medical counseling for the FDA-approved drugs. It does make a difference what the patient has tried before. Studies show that if everything else is equal, you allow a patient to select their medication, and you as a physician believe that the benefits and the risks are equal. The results show that outcomes in smoking cessation are higher in the group that A, the physician dictates the treatment, or B, the physician allows the patients to choose. It's B, right. Great studies, interesting studies, and the difference is significant. And then supplemental information, 1-800-QUIT-NOW. All of this can be done in brief visits. If patients unwilling to quit now, encourage smoking reduction and suggest NRT. Now, this is a big difference from past years. Good studies now show that if somebody is interested in quitting and they're wanting to cut down and so on, if you offer them nicotine replacement therapy and they begin to cut back on their cigarettes, you have significant increase in quit rates. So Dr. Fagerstrom is one of the first ones to show that about 10 years ago, and many other studies have now shown that. In addition, motivational interviewing and then following up with the 5 A's and the 5 R's. These are the drugs that we use. These are the first line. We also have second line. These are not FDA approved for treating tobacco dependence, clonidine and nortriptyline. It turns out that they do work, and in some patients, you may end up wanting to use those. Combination drugs I mentioned, the first line would be NRT, long-acting patch, for example, plus a short-acting agent, gum inhaler, or nasal spray. I would mention that this has not been FDA approved, but the science indicates that this is a reasonable thing to do. It does increase the cost a bit, but the toxicity is minimally increased, and it works. Acute dose titration, of course, occurs as you add the gum inhaler or nasal spray. And then bupropion SR plus nicotine patch is an excellent combination. Drugs are not recommended in various populations. Smokeless tobacco users, there's insufficient data here to support their use. There's some data to suggest it, and clinicians will use it, but we just need more data. Similarly, in individuals smoking a little bit a day, less than 10 cigarettes a day, it's not clear. The studies typically do not look at smokers at that level. And then finally, adolescents, again, there's nothing to suggest that treating adolescents with the approach we just used or suggested here would not work. In fact, the evidence is the opposite. The problem is we just don't have good prospective studies that have documented that it's used. Yes? E-cigarettes. I'm going to mention that in a little bit. Yeah, I'll get to that. It does contain aerosolized nicotine, so it is addicting. So the medications, you have to decide risk and benefits based on the medical or psychiatric status of the patients. Now, a little bit about some warnings here. In general, drugs used for smoking cessation are well tolerated, and the risk profile is pretty reasonable. I've given you a piece in your handout, and that fold-out brochure shows you in detail what some of those risks are. So you've got this information. But I want to pay a special attention to some new data that has come out. First, in 2009, you have boxed warnings for Chantix and Zyban for neuropsych problems. And this includes agitation and aggressive action, suicide, depression, and so on. And just to show you some of the data, acts of violence towards others, this is a study using FDA data, which is voluntarily submitted to the FDA. So there are limitations on what you can do with the research, but this is about as best as you can do. And as you can see, varenicline has a PRR, which is proportional reporting ratio, which I can't go in right now, but the science behind that is pretty good, of 18 versus bupropion 3.9, nicotine 1 point plus. The conclusions of this paper is that varenicline and antidepressants were the most strongly and consistently implicated drugs. Now, these researchers looked at all drugs, and they found that the drugs used, varenicline and antidepressants, were at the top of the list. Now, suicidal behavior and depression, smoking cessation treatments, these data from Moore this year. These authors are from an institute for self-medical practices in Alexandria, Virginia, from Wake Forest, University, Harvard, and Johns Hopkins Medical School. This is a very busy plot, and the only thing I would mention here is the odds ratios for varenicline here for these neuropsych events is 36.6 versus bupropion 12.5 and 4.3 for nicotine replacement therapy. That's troublesome to the point where these authors indicated the findings for varenicline combined with other problems with its safety profile render it unsuitable for first-line use in smoking cessation. Now that is a very, the reason I'm bringing it to you today is that is a very bold conclusion of researchers. And we need more data. We desperately need prospective trials, but unfortunately we do not have a research mechanism in the United States that easily allows one to do the kinds of trials you need to follow up and verify or invalidate the conclusions of the best science using the data as it's available, which is data reported by you to the FDA. And that's the basis for this research. And you can poke holes in that in terms of the research, these investigators, it turned out, did a heck of a good job in presenting the data, I think, certainly to the point where I think all of us have to just weigh those risks and those benefits out there, okay? That's all I can say. So in addition, varenicline, unfortunately, has been recently found to have cardiovascular risks, and you're probably aware of this. And shown here are the data: increased risk with varenicline, up arrow, decreased risk over here, and here's where we are. And so there is a statistically significant incidence of serious cardiovascular events associated with varenicline. So in a patient with underlying cardiovascular disease, many of them are smokers, we now have to be a little bit cautious about prescribing this drug. Okay, let's shift to the quit line, office-based strategy, Quit Now, Indiana. And here we have an intervention, less than 3 minutes. Ask, advise, and refer to 1-800-QUIT-NOW. Recommend a medication if appropriate. That's perfectly fine. You can get engaged by yourself as a clinician. This just tells you what a quit line is: toll-free, evidence-based, trained coaches, free and confidential, easy access. But this allows you to get engaged from your office, filling out a little form, you fax it, and then everything is taken from there. The quit coaches will contact the patient, or the patient can contact them, and then you get feedback in your office. So this is an excellent way for people that don't want to quit in groups. They would rather quit in their own home. There is a preferred provider network now, which you can join and get information regarding updates in smoking cessation and so on. And this just has some information where you can go and get that information at these websites. Now, yes?
Where is this controlled and who's
The State Department of Health, and under that, the Tobacco Prevention Cessation Commission.
So it's only Indiana?
It's all over the country.
Okay, so who controls all over the country?
Various states. And then you have big organizations like National Cancer, NCI, and others.
Funding is from?
Funding is from, in Indiana, a mixture of sources. Some of it comes from the Centers for Disease Control. Some of it comes from in-state sources.
The providers are healthcare personnel or just specialized coaches?
The providers are nurses or specialized coaches who have about 240 hours on average of training, a lot of training. And we contract with a group in Washington, Free and Clear, I believe, unless we've changed that contract, state of Indiana. And so the call will come from probably Washington State. And randomized controlled trials show that quit lines work. So it's really great stuff. By the way, it's free. It's free, no charge to the patient. And nicotine replacement therapy for a couple of weeks, free. Now, a couple of quick things. E-cigarettes you mentioned. You brought up a great point. You're going to be seeing people coming in with all kinds of dissolvables and e-cigarettes, et cetera, et cetera. The bottom line is we have a great concern about these things. One is nobody in the world has shown with good science that these things are either safe or effective for what they're intended for. So that's one thing. We do know that they contain aerosolized nicotine, but they also contain other chemicals. And the nature of those chemicals varies depending on where you get these things. And they're made all over the world and shipped into the United States. So it's really buyer beware. So as a result of this, public health folks are not really inclined to recommend this. Why do that when you have alternatives that are proven to be safe and effective by the FDA? And so that's kind of the issue. Now, these are being marketed by the tobacco industry for dual use. They want kids or adults to use these, but they also want them to use cigarettes. We already have data to show that young kids who start out with these or the dissolvables, about 30% of them in early studies shift over into cigarettes. So one of the great concerns is that has the tobacco industry just figured out a new way to addict another generation of people? So that's a problem. Let me mention pregnancy, mental illness, obesity, surgery, and just a couple of quick myths, and then we'll be done. These are the dissolvables I talked about, the strips, the sticks, the orbs. Little kids can get a hold of these things, put them in their mouth, melts on their tongue. You as an adult, you as a parent, do not know what they're doing. Teachers in school have no idea what they're doing. And this is out there. Snooze, the little thing you put between your lip and your cheek. You cannot see that, and you don't have to spit and cough. Okay, so that's another problem. Yeah. Yes, yes. The amount of nicotine was really scary. You know, one cigarette's got a milligram to 2 milligrams of nicotine in it. That'll kill your Fifi or Fido, your pet, who eats it, or it could kill a young child. Now, the reservoir, the containers that are sold to fill the reservoir inside an e-cigarette contain, some of them contain 10 milligrams to 100 milligrams of nicotine. That's enough, you know, to hurt a lot of people. So there's a concern about poisoning and so on. The answer to your question, though, is already there have been documented cases where these products are injuring or, in fact, killing some individuals with toxic poisonings. Yeah?
How they are selling it then?
I'm sorry?
How they market what they're selling it for? They say that it helps you quit smoking, or?
The tobacco industry, you'll have to ask them why they're marketing this, but for those of us in public health, we pretty much know why. One is they're getting huge pressure on secondhand smoke. So this is a way to reduce the likelihood that somebody smoking an e-cigarette is going to get kicked out of an airline or an airplane overseas or so. And some countries now allow e-cigarettes. Our airlines do not, and many others around the world do not allow smokers to relieve their addiction with e-cigarettes. So the tobacco industry is specifically marketing e-cigarettes for that purpose. Does that make sense? So when you can't smoke a cigarette, smoke one of our e-cigarettes. The second reason is that they're suggesting that you can quit smoking easier with this. And we have no data to support, no good scientific data to support that contention. So, yeah.
What about the e-cigarettes that are nicotine-free? Would that be a way to get them to cut down?
The problem with that is nobody knows which cigarettes are nicotine-free and which aren't. There's a recent study from Europe that shows the e-cigarettes there contained close to 100% of what they were supposed to contain. Other studies show they contain 10% of the average amount of nicotine that you would obtain from a cigarette. Does that make sense? So we have no idea because nobody's regulating these products. And they're made all over the world. And the quality control is,
So if they're advertised as nicotine-free, they're probably
probably
not.
not. But you have just no idea. Plus you have no idea what else is in there as well. So it's kind of scary. Okay, so here is in the New England Journal of Medicine, Dr. Cobb just mentioned, until the FDA asserts authority under this act that I mentioned, manufacturers can continue to sell concentrated nicotine direct to consumers, and this raises safety concerns. Now, let's flip to pregnancy. Just a quick word about pregnancy. Indiana has a problem with women who are pregnant smoking during pregnancy, and we know that's a huge problem for the fetus as well as the mother. We also know that drugs have not been proven safe and effective. We just lack that information for obvious reasons. It's difficult to study these drugs in pregnant women. The recommendations, therefore, today are to offer person-to-person psychosocial intervention that exceed minimal advice that I just mentioned. The strength of evidence for this is A. So you need to set up in an office setting a facility so that you can address the needs of your smokers accordingly. Does that make sense? Okay, some tobacco myths in terms of mental illness. Recent publication by Prochaska, who's a leader in the field in the New England Journal of Medicine this year. Tobacco is necessary to self-medicate people with psychiatric illness. Myth. All of these are myths. People with mental illness, no interest in quitting. People with mental illness can't quit. Quitting interferes with recovery from mental illness. Smoking is sort of a trivial or low priority issue in terms of acute psychiatric illness. All of these have been shown in good science to be myths. So the bottom line is offer treatment to all patients, and the good news is that providers like yourself and others are effective in counseling such patients with alcohol, drug, and mental disorders. So primary care physicians can do this. I would consider consulting with an addiction specialist because it gets tricky when you have somebody with comorbidities, other medical illnesses, and you're using CNS active drugs. As you guys know, that gets tricky. Now, what about obesity? Just look at the quit. Men, women, baseline follow-up after smoking. What happens to the weight? Zooms up, right? It's a significant issue. And these data from Dr. Benowitz. Now, it turns out, let's go through just a little quiz here, and I've given you a clue as to what's the correct answer. Actually, I've given you 2 clues. It has to do with color and font. 20% of smokers are obese. What do you think? True, right? Morbidity and mortality of obesity outweighs the benefits of smoking cessation. False. What happens is you narrow that gap. With obesity, you drive up the risk of diabetes, hypertension, etc. But you would have to be a balloon person, right, to get close to the adverse effects of tobacco. So your patients are going to ask you that. Third, true or false, weight gain after smoking cessation contributes to the risk of diabetes, hypertension, reduces improvement in lung function. True. After 6 months, benefits of weight control treatment are no longer significant. True. True or false, meds for post-cessation weight gain, bupropion, NRT, etc., delay but don't prevent weight gain. Also true. Now here is a real interesting one. True or false, reducing concerns about weight gain rather than control weight gain may be more beneficial for smokers who desire to quit but are worried about weight gain. And these data show one study that is recent, Archives of Internal Medicine, that shows a group allocated to the concerns intervention for patients, that is focusing on their concerns about the likelihood they're going to gain weight, plus bupropion versus standard plus placebo. Now let's flip to surgery. Myth, it's dangerous to quit smoking shortly before surgery. It is not. Family physicians, anesthesiologists, surgeons all have a teachable moment. So as primary care physicians, your patients are going to surgery. Be sure to interact with the patient and the surgeon to encourage them to take advantage of this teachable moment. Because studies show that if the surgeons and anesthesiologists do, quit rates actually go up. So good news. Recommend the Ask, Advise, Refer 1-800-QUIT-NOW. Reimbursement, I've given you some information in your packet regarding reimbursement and some places to go for questions about reimbursement. Questions? Yes, sir. First, yeah, go ahead. Yes. Yes. Yeah.
So, are we doing any work? So in the future, we don't know what's going to happen with the payment system for your performance or stuff when you care for the patient. So most likely it's going to be more toward about better results, what you really did for the patient.
Yes.
Now, there's
Yes.
also other side of things that we want to hold people accountable for their actions. So if you're a smoker, then, for example, not going to pay for your lung cancer treatment, or if you are alcohol abuse, you will not get a liver transplantation. So is there any work being done in this area, for example, in the schools first to let the kids know, because we don't know the future, how the future is going to look like.
Well, you're raising a very good issue, and that is, it's one I tend to agree with, and that is we have to do a better job from birth in the family unit, et cetera, in letting mothers and dads know how critical it is that their child not be exposed to smoke and not end up smoking. And that kids at a young age, learn that they have choices to make. And it's critically important that they try to make good choices, one of which is to not start smoking. Now, moving on, so that's one thing that I don't think we've done an adequate job in myself. Now, I might sound like a pro-tobacco person here because tobacco has made a fortune off of blaming the victim. That's a typical strategy of tobacco. But there's some truth into responsibility, for sure. Now, your question, though, went off into another area which we don't have time to get into, and I do not have expertise in the area in terms of studies that have looked specifically at the ethics and practicality and the cost benefit and et cetera of making decisions about who can go for a certain treatment and who can't. In other words, rationing. But clearly we're already rationing, and in any future healthcare system we're going to continue to be rationing in some way and making some tough judgments like that. So it's a great question you raise. Eric Meslin at the Bioethics Center might be a guy to touch base with in that regard, and maybe Frank can comment on that. Was there another question? Yes, sir.
What about the cost of generic nicotine patches versus 1 pack a day?
1 pack a day depends on what you're smoking and where you are, and it can range from, well, as you know, the cost in New York or whatever with all the taxes, et cetera, maybe about $6 a pack, whereas in Indiana it's much less than that. So you almost have to, that's a very good question, you almost have to put that in the context of what the price of cigarettes are in your community or tobacco and what the price of the nicotine replacement therapy is. And as you guys know, one of the frustrating things, and I think the good news, Frank, we were talking about this earlier, about moving more into models of healthcare where we can work in some kind of a collaborative way together and have the power to demand that you, when you make that decision, you have that information in front of you with your patient. You don't have it today, do you? I mean, you don't have that information. I don't have that information. Frank doesn't have, none of us have that information. And yet, to make a prudent decision about which way to go. Now, in terms of a choice, obviously, nicotine replacement therapy and tobacco is not a good choice. The cost of continuing to smoke is your life and all the consequences of it. But the practical issue is, can one afford the cost of nicotine replacement therapy? One of the reasons the Quit line made this free up front was because we have good data to show that the higher that cost is, the less access people take to smoking cessation programs. Some have even suggested that you make it free because the cost savings would make sense.
You have to have a prescription to get a nicotine?
Over the counter.
So what do they cost?
It just varies. I mean, it can go all the way up to $70 a month, $80, $120,
Well, I don't think
50.
nicotine replacement products are over the counter.
Oh, no.
But some are.
That's right.
They are in the sprays.
They are prescription drugs. And that information, by the way, is in the fold-out brochure in your packet. It shows you the over-the-counter and the prescription. Yeah, spray, inhaler, those are prescription.
Medicaid pays for them as well.
Yes, they do. They do, indeed. Yeah. One more, or one or two, and then we need to go to Frank. Yeah.
Yeah, it is true. Patients are coming in, and they're coming in with their e-cigarette, and they're excited about it. They think it's cool, it's realistic. I guess we need to tell them to perhaps. I have been neutral. I haven't told them to not use it, but maybe we need to redirect them on
As a physician, yeah, I mean,
the right drug.
and you have to do it carefully and thoughtfully and individualize it, as you know, because I just told you that people who choose to take their medication do better than people who don't. And in this case, they're choosing an unproven drug, but you have to be sensitive to that. I would just let them know that we don't really know what the hazards are. We know it's costly. So the e-cigarettes versus NRT, the e-cigarettes.
It's like $100.
Yeah. I I mean, so it's definitely expensive. So, yeah, but it's a good issue. And this is an unsettled area. We really don't know exactly where this is going. So, but for right now, we have no scientific data to support the use and recommendation of the use. Yes, ma'am, last question.
Have you ever had a cigarette smoker that would tell you how much it costs them per month? Because most of them, if you say, I'll give you a prescription, they won't have the money to buy the prescription. But they will have the money to buy their cigarettes.
Yeah, actually some research has been done. The patients that I see a lot now down at Geneseret Free Clinic, a lot of them get their cigarettes probably from IUPUI campus. Just they go around to the hot spots, you know, and pick up the butts and so on. They borrow and they buy. And you're right. The prisoners of war in World War II in the Nazi prisoner of war camps, I was asked this on the witness stand, by the way, in a famous trial. And I had to read from a book that I was unfamiliar with that accounted for or recounted the stories of people who were starving to death, who traded what little food they were given for what? For cigarettes. Yeah. So there's a strong urge. The social, cultural, financial issue that you raised is an important one for sure. But we have to remember we're talking about an addiction which is a potent addiction. So, you know, people are going to do whatever they need to do to get the cigarettes. So, thank you very much. I'm out of here. Frank? If you have questions, you can email me at sjay@iupui.edu.